He wasn't in the right sense of mind mentally. He'd been going through a lot over the last year. Out of a timber so crooked as that from which man is made, nothing entirely straight can be built. Immanuel Kant, 1784. Hi, I'm Frank Speidel, and welcome to The Doctor Is In. I'm a retired emergency physician and recovering hospital administrator. In this show, with the help of guests, we explore healthcare in the United States and its interface with society. Now, I invite your robust skepticism of my comments. I'm human, and I make mistakes. Always defer to the guidance of your primary physician, local health departments, or the CDC when looking for direction in healthcare. The scalding foolery of Uvalde and Buffalo are not the most recent incidents of foul murder of innocents. The imbecility of the July 4th parade murders in Highland Park is the most recent. The majority of our country wants to respond to preserve the most basic and primal of our rights, the right to life. Overwhelmingly, we find ways to prevent and deter mass murders and violence in general. That's what our goal is. We owe it to those who have died to shed our comfortable ideas and make a safer world. You will see a slide showing the steady rise in fatal shootings in Philadelphia over the past 5 years. And then you'll see a slide that shows a 2022 New England Journal of Medicine report on the causes of deaths of children under 19. I note since 2019, firearm and overdosing deaths have gone vertical. Now, one of those comfortable and curious ideas, I think, is with more funding for mental health, we will solve our problems of gun violence. First, a confession. I'm not sure what mental health is. I've spent 4 decades practicing emergency medicine, seeing the ill, the injured, and also the troubled and the distressed and the marginalized. I found overwhelmingly the majority of those labeled as mentally ill are nonviolent. While I think funding for mental health is desirable, I think it will not have a significant effect on human violence. I note others share my skepticism. In this slide, you will see that the national agencies that are weighing in that mental illness is not always violent. The American Psychiatric Association joins in too. You'll see it in another slide. Now, I note that 2/3 of deaths by firearms are suicides. Now, I think that many suicides meet the Diagnostic and Statistical Manual of Mental Disorders, DSM, criteria for major depressive disorder. DSM has been published and edited and revived by the American Psychiatric Association since 1952. In their ever-mutating Diagnosis and Statistical Manual of Mental Disorders, DSM, first published in 1952, the most recent version is DSM-5, and it is a consensus of experts, a compilation focused almost entirely on the diagnosis of behavioral and cognitive issues. Most of the contained diagnoses have no biologic marker. What's a biologic marker? Well, if we see a patient with abdominal pain, we're thinking of appendicitis, I can look at the white blood cell count to see if it's up. Or I can get a CAT scan to see if there's tissue changes around the appendix. If I see a person that's confused, I can get a CT if I think it's a bleed in the head. That will show up. For renal failure, I can follow the BUN and creatinine levels. Despite work in functional MRI for schizophrenia, there are no biologic markers, no blood tests, no imaging studies to aid in the diagnosis of depression. What studies can lead to that diagnosis? Now, 2 observations. I've been told emergency medicine is the front row seat in the theater of life, and nothing is new under the sun. On June 16th in Easton, Massachusetts, a 46-year-old drove his car into a store selling Trump material. His friends advised he had been hearing voices and he wasn't in the right sense of mind mentally. He'd been going through a lot over the past year. When I was in my residency in emergency medicine working in an emergency department in Northeast Philadelphia, I saw a young man come in police custody. He was transported by ambulance and he was wearing shackles. He had been in a convenience store and had gotten into a disagreement with the staff. He left, I was thrown out, and when he left, he drove his car into the window. Let's call him Frankie. Frankie was seen by the ED staff, and we would see him and his family many more times in the courts. His family arrived and they demanded he be released. He wasn't violent, they explained. The cops, and he told the cops he had mental problems. Since childhood, he had a history of disruptive behavior, triggered by conflict. He had been seen at the university hospital, worked up, and had a diagnosis. They had a letter from his primary care physician explaining his diagnosis was fugue state. After the police uncuffed Frankie M., he proceeded to sucker punch his father. A fight ensued with Frankie's family and the Philadelphia police who were present. This resulted in an assist officer call. If you've never seen one, it's quite an event. In court, I got to hear the family physician in person pedantically declare Frankie M. suffered from fugue state, now labeled dissociative state. Since childhood, conflicts would trigger a fugue state, and he would not remember what happened, so he could not be responsible for what happened when he was in a fugue state. Through my career, I have seen and treated many perpetrators of violence, including murderers. They all had a DSM diagnosis. However, they had competence, insight, judgment, and orientation. Some were bright, some were dull. Some were remarkably capable of self-control and manipulation. Many were delusional, but no one was hallucinating. But they all tested reality. They correctly sensed the stimuli the world outside of their minds was providing. To bring understanding to these issues, I am delighted and honored to have as our guest today Professor John Kurtz. Professor Kurtz, Dr. Kurtz, is a licensed clinical psychologist and professor in the Department of Psychological and Brain Sciences at the University of Villanova. His PhD dissertation, Differential Information Processing and Borderline Personality in Major Depressive Orders, I find remarkably apropos for our show today. His publications on personality shine and radiate. Professor, welcome to the Doctor's Inn. What did I get wrong?
Frank, thank you very much for having me on your show, and I don't think you got anything wrong. It's hard to get much right in the world of mental disorders. Is extraordinarily complex, and I think you captured that complexity very well in that opening.
How'd you get interested in psychology?
I think it was a long, slow burn. When I was a child, my uncle collected books, and he was always giving me his books, and he gave me one that was a personality test that was based on drawings. So I like to give that to friends and family members, and I think that kind of planted the seed of interest in testing. But I didn't think of it as a career until I was in college, and I took my intro psychology course. And
where'd you go to school at, by the way?
University of California, Berkeley.
Cool.
Yeah, so I'm taking intro psych with 850 students, and a lot of students complained that they thought the professor was boring, and that this was boring, and I was like, I don't want to do anything else. I found it. This is what I want to do, and it just intensified from there as I progressed through the major, and I took a course in testing and measurement, and that when we're finding an identity, we search broadly, and then we start to focus more narrowly, and I got to where I am now.
It sounds like that has a significant quantifying background to it.
Probably.
Running the numbers to get the answer.
Right. We're always doing that.
What are delusions?
A delusion is a belief that is inaccurate, that is not shared by the evidence or by the people around you. And it usually originates from the person, him or herself. And it's a belief that is nagging at the person, that feels really true to the person who holds the belief, but no one else holds it.
Contrast that with a hallucination.
Yeah, hallucinations also are sort of internally generated. It comes from the person. Hallucinations are usually auditory. hearing things that other people can't hear, but sometimes it can be seeing things that other people can't see. Sometimes they're tactile. You feel like you're vibrating, or they are sensory experiences that aren't shared by other people, whereas a delusion would be thoughts, cognitions that aren't substantiated by reality. But they feel very real to the person.
So the delusions, the person is sensing the world outside the way you or I would sense it, and everyone else in the room would sense it, as opposed to the hallucination where there's something not from external stimuli, or at least not well reflected from external stimuli, inside of them that causes them. You're mentioning about auditory hallucinations. I associate that almost always with schizophrenia, as opposed to there's many metabolic cases, everything from Parkinson's syndrome to little kids when they get septic, and when they get sick, when they get a temperature, they'll be talking to Mickey Mouse and they'll be pointing them out to you and stuff like that. And but the auditory hallucinations are a little bit different. Do schizophrenics, having mentioned them, do they have an increased incidence in violence?
Well, it depends on what you're comparing them to. So, we like to say, well, people with schizophrenia can behave violently. They don't usually. It's a small percentage. Roughly 1 in 14 cases of schizophrenia needs, solitary confinement or other protective measures to prevent them from hurting other people. About 1 in 14. So it's the great majority of schizophrenics are not violent. And those who are, it's typically due to factors that make other people violent too. So it's typically violent schizophrenics have a history of being aggressive in childhood, or they've got a comorbid substance abuse disorder. So substance abuse is also associated with acting violently.
Yeah, let me back up for a second. You're touching the fact that they're psychotic, but we know that substance abuse can provoke wonderful psychosis, remarkable psychosis. And they're hard to sort out, aren't they?
Exactly. So people, we want to talk about schizophrenics, and this highlights the problems you were talking about with systems like the DSM that want to create categories of mental disorder. The problem is people often fit into multiple categories at the same time. So just because someone's schizophrenic doesn't mean that's all they are. They could have antisocial personality disorder layered on top of that, intermittent explosive disorder, substance abuse. It's extraordinarily complicated. People are multifaceted, which is why it's really difficult to make generalizations about, say, these mass shooters that you mentioned in your introduction, and any kind of mental disorder, because it could really be a lot of different things.
John, you had a wonderful comment on what you're talking about. Usually the person who does mass shootings, how do you see them in terms of antisocial, in terms of suicide, in terms of psychopathic behavior? Talk about that for a minute.
It's a great question. So I think some of the characteristics of the mass shooters differentiate them. So the two that are really in our consciousness until this unfortunate incident over July 4th were Uvalde and Buffalo. And they're, interestingly, it's both in cases an 18-year-old male, but they're different. So in the case of Uvalde, it's more senseless, who would shoot kids? There didn't seem to be any political point to it. So in the case of Uvalde, it sounds really like a suicidal depression. Typically someone who commits suicide and takes a bunch of other people with them, tends to be young, tends to be male, and tends to feel like they've been really deeply wronged in their experience. And they're angry, and they're basically suicidal, and unfortunately they want to take other people with them.
Does that parallel the Las Vegas shooting, which was the largest mass casualty?
That one's a bit mysterious. I've not really heard as much follow-up on the person, but it certainly sounds, again, like with older male, but again, we have a male who, I think wanted to kill himself, and that anger, it wasn't enough to turn it on himself. He wanted to bring a bunch of other people with him. Now, the case in Buffalo is different. So the case in Buffalo, it's interesting you talk about delusions, because the person who did the shooting in the supermarket was acting on a belief system, acting on what he thought was a rational act. in order to defend some principles that were, of course, illogical and ridiculous. But it's not a delusion, because the idea came from elsewhere.
Yes, and this is the challenge we have in a society with free speech. We tolerate ideas being out there, and I think personally we have to tolerate every bad idea has to be spoken, and the answer is not censorship, but rejection of it and condemnation of it loudly and vigorously. But the Buffalo shooting is just stupid ideas said by people in their own little circle, and they feed off one another.
And those circles can tend to become vortexes, where you
Absolutely.
become immune to other information.
Absolutely.
Because part of what that circle tells you is to not trust what you're seeing in the media, to not trust what sensible people say. So in a sense, it's kind of like a mass delusion.
Absolutely. It's some people would say that there have been some religious movements that have had that same kind of the Jim Jones time in life, that embrace this kind of delusional, magical thinking. Oh, by the way, I want to ask you too, dementia.
Dementia. Often neglected in discussions about mental disorders and violence, because we don't think of dementia as a mental disorder in the same way we think of depression or schizophrenia, because it afflicts people in their later years. They're less visible, so people with dementia are more likely to be institutionalized. So I think they just don't really enter into our consciousness, but they are a big risk for guns. And here we don't have a case of delusion or hallucination or antisocial personality or anything like that. In this case, it's just pure organic confusion. So somebody with dementia wakes up in the middle of the night and they don't know where they are. They don't remember their home or the place they're in. And they see somebody, it could be their spouse, and they mistake them for an intruder. So that's a situation where you really don't want to have a gun in the house.
The organic basis of this, where they've lost that higher cortical executive function that enables to sort out the stimuli from the outside world, and they can go down the wrong road, can't they?
Right. Well, and as dementia progresses, your understanding of your current situation becomes outdated. Now, part of the reason you don't recognize your spouse is because your concept of your spouse starts to get trapped in an earlier point in time, and you think, who is this old person in my house?
Strangers are not stranger. Tell me about bipolar affective disorders. Do you see them as having any?
They have about the same risk of violence as schizophrenia or any other major mental disorder, but more often, just like you were saying in the beginning of the show, the bipolar person is a risk to themselves. So they're a bigger problem of self-harm and suicide than they are hurting other people.
Well, this gets to the heart of this. Are there any DSM diagnoses that you think have an increased incidence of violence? Goal-directed, thought-out, purposeful violence.
Intermittent explosive disorder. It's basically defined as somebody who just, is easily ticked off and acts out their anger in explosive ways. So, if there's a problem, the DSM will find a category. So the antisocial personality disorder, and the old term for it, the psychopath. And the psychopath arose from there were a number of cases, and made famous by Hervé Cleckley, who was a psychiatrist back in the 1940s and saw all these patients, and they didn't fit into the diagnostic taxonomy of the day. They weren't clearly psychotic people. They weren't clearly neurotic people. They actually seemed normal. They were wearing a mask of sanity, and underneath it was a terrible monster who could do terrible things. And that's where the psychopath came from. But like I say, the psychopath is not as likely to be a mass shooter because they tend to act in ways, instrumental ways, that are going to benefit them. So their impulsive actions are usually in the service of some kind of rewarding experience or benefits to them. Like you defined them at the beginning, they don't care about other people, so they're mainly looking out for themselves. And certainly going into an elementary school and shooting up a bunch of kids so that you're going to get killed yourself by the police is not their modus operandi.
I was stunned. Part of my, I think sometimes when you go into clinical medicine, you lose a lot of innocence, and you have experiences that are forgive the weighty word, transformative. I got to see a lot of murderers. In our society in the United States, when somebody does something bad, many arresting police organizations have a protocol. They will bring that person to the emergency department to have them evaluated, to get a baseline, to get somebody else's opinions, and also to document that he hasn't been beaten up by the police or shot or injured. So when you work in the emergency department, you get to meet a lot of people you would not normally. However, I have had the occasion to meet several murderers before they were arrested or convicted. One in particular was building a defense. I saw this individual, a total of, he was seen 3 times, I saw him twice, and he was building a mental health disorder defense.
Okay.
He was arguing that he would wake up, all of a sudden, I'd be driving my car and I'd find myself in Overbrook. And he'd have these stories. The thing that most amazed me about him, Professor, was this guy was so clever and so manipulative. He thought he was smarter than everybody else. He was making fun of the people around him. He was abusive, and he just couldn't wait to tell a story. And when he told a story, he had to include things that showed how much smarter he was than everyone else. This individual was a teacher, and I vividly remember him announcing very proudly at the start of one of the stories, "Well, I'm taking Latin during the summer." Okay, I'm impressed. But clearly, he touched base with reality. He had a plan. He was doing things to make this plan happen. And the challenge of these people is they can turn it on and off. This guy was very violent when he just had one person. When no one else was around, or when he passed for normal, he was a respected high school teacher. Challenging.
So that sounds like a real classic case of a personality disorder. So, and that was the confusion collectively was facing, is that these people they can keep it together when they want to. Unlike a person with depression or whatever, where they feel overwhelmed by illness. There are people, and the personality disorders are different than other mental disorders. They used to be, in the earlier iterations of the DSM, they used to be in a separate category, on a separate axis. And that was because they were thought to be lifelong developmental problems. They were problems that, stretch back into childhood, and they were not going to be as easily treated by, medications or even psychotherapies. They were much more of a challenge. So they had to put it on a separate axis, say, okay, well, this person has depression, but they also have a narcissistic personality disorder or borderline. So, whoa, fasten your seatbelts. The prognosis is different when the personality disorder is layered on top of episodes of mental disorder.
In the personality disorders, what are clusters?
Well, so again, that's based on the categorical kind of thinking about disorders. So there are 10 of them, and the 10 sort of cluster into 3 categories. So we've got your cluster A's, which are your odd, eccentric people, schizoid, schizotypal, and paranoid personalities. Then you got cluster C, are your anxious, fearful. These are your dependent. They put obsessive compulsive disorder in there, although that's not a real good fit. And your avoidant personality disorders, but really the personality disorders that cause the most disruption, that really have the most research on them, probably most frequently diagnosed, are the cluster Bs. This is your antisocials, your borderlines, your narcissists. They used to, histrionic is kind of a silly category. So
I trip over histrionics all the time. I used to in the emergency department.
It's a real personality. Is it a disorder? Is a little more debatable.
When the histrionic is trying to seek the approval of people, they can do some really maladaptive things.
True.
And that's part of the challenge, especially for the family, who have to try to waltz this person into a functional life. Now, treating personality disorders? A lot of success? What techniques are used?
Well, the literature's pretty clear that when you have a personality, so there's like treatments, like cognitive therapy for depression is a classic one that we've studied for decades. It's quite effective. When there's a comorbid personality disorder, your outcomes are not going to be as good as if it's a clean case of depression. So when the pharmaceutical companies, they run their clinical trials to show how well Zoloft works, they typically like to make sure that, we just have uncomplicated cases of depression, not someone who's been struggling with borderline personality disorder and has had multiple episodes in and out of depressive syndromes. That person will be a lot harder to treat.
You mentioned earlier, Professor, and I thought it was spot on, there's no sharp discreteness to these things. There can be an awful lot of overlap. In the overlap for substance abuse disorder, I mean, my Lord, depression, psychotic behavior, this whole thing starts swirling. They aren't very discreet, and that's where part of the challenge comes, sorting out what to do first.
Correct. And, really, we have kind of the same approaches to everything. I mean, so we talk about antidepressant medications, but they're used for a lot more than depression. They're used for sleeping problems. They're used for eating disorders. They're used for pain. They're used for, so it's sort of a one-size-fits-all. We would like to think, I think that the original inspiration of psychiatry to develop these categories is that we would find that, what you were referring to in the beginning, that underlying organic basis, we could get the medication that would target that exact thing, and life would be good like it is in the rest of medicine. Or we can treat things successfully, and so psychiatry is, I admire psychiatrists. They're going into a difficult branch of medicine.
I especially respect that. That is not a simple, straightforward. Last question, real quick. What's the McNaughton rule?
So that is where I believe, so it goes back to 1843 England. So McNaughton was a guy who shot a man in London, but he believed he was the prime minister, but he wasn't. And so the first case of somebody who got off for reasons of insanity. So insanity is a legal term. It's not in the DSM. It's not something we bandy about in the mental health professions. But insanity is this idea that you don't know what you're doing, and you don't know that whatever it is you think you're doing, you don't think that it's wrong. You don't think you're doing anything wrong. And insanity defense is very rarely used, and it's very rarely successful, contrary to public opinion about, people get off, but they don't.
No, thank you very much, Professor. I am honored to have you here.
It's been a pleasure.
You've brought some light to this unfortunately timely topic. I'd like to close by sharing with you that I've never found it written up, but during my education, there was an old psychiatrist who shared that that personalities drove a lot, that we are born with an infantile personality where we see ourselves as the center of the universe. The only thing that matters is what we want, when we want it, now. I'm hungry, I need to be changed. We develop attention-seeking behavior to get the adult in the room, to take care of us, to feed us, to change us. That somehow society and culture manages to grow us from that inward-turned obsession and fixation on only ourselves and only what matters to an outward-facing personality where our joy and delight is not having our way and not getting everything we want when we want it, but to seeing the world around us and the people around us that we relate to, our family, our friends, and even strangers, understanding and putting a pattern in an organization to it and adding to that world around us in a positive way. That was the adult personality. Perhaps as we close today, we can hope that we all grow as a society into adult personalities, and we have a thought and a kindness for all those that are suffering from the irrational violence that besets us. Thanks for watching The Doctor Is In, and stay safe out there.